Welcome to A Journey to Whole Woman Health, the podcast where science, mental health, and faith come together to educate, empower, and encourage women in every season of life. We're your hosts, Dr. Jamie Irwin, board-certified OBGYN, and Dr. Mary Catherine Nader, licensed professional counselor with a PhD in counseling. Let's begin the journey.
All right, we're back.
We're back. Happy Wednesday. Welcome back to A Journey to Whole Woman Health. How are you?
I'm good. I'm excited to do this again. It's so fun. We had so much fun the first time, and it's another Wednesday. We were laughing about on Wednesdays we wear pink.
That's right. We sure do. We're halfway through the week.
Yes.
Let's keep it going. Well, hey, I'm in midlife. What about you?
For sure. Definitely feeling all the things of midlife.
Mm-hmm. We were on our way here, and we were both like checking our abdomens, making sure we had placed our estradiol patches. Like, did I remember to put it on? And we did.
It's patch day as well, Wednesdays.
Oh, it is.
Yeah.
We got a lot going on this Wednesday.
It's a big day.
Yeah, it's my patch day today too. Yeah. So definitely in midlife, you're there when you're getting your mammograms.
Yes.
I got that done.
Mm-hmm.
I guess it was last week. And I have to give a very special shout out to Jackie at the Solace in Waterside.
Oh, nice.
She is a boss.
I think she's helped me, actually. I feel like she was the one who helped me with my last mammogram, now that you're saying that. Because I remember looking at her name because my previous experience had not been as great at a different location.
Okay. Do you want to share about that?
I mean, we've mentioned my fainting issues before, and you kind of referred to this previously. But it's just there's so much happening. Like, they're putting your hand up. They're like, pulling on things that you don't want to be pulled on, and they give you that cape. Why? They're just gonna remove it. And so anyway, the time I had gone before for a mammogram, it had been very quick, very simple. Mm-hmm. And this time I went, it was right before lunch, just thinking about it. I'm like, oh. And I was like, I had lunch plans after, so I was like, I'm just going to go get this done. Mm-hmm. So I had worked out, but I didn't eat anything, not smart. Mm-hmm. Of course, it ended up being a long wait. Finally get back there. It was hot, so hot in the room.
Oh, no.
And, you're in this super awkward position, with like, just don't breathe, hold tight.
Yeah.
My knees are locked, and I have to just stop them and say, I'm so sorry, but I think I'm about to pass out. And all I can imagine is me passing out with my boob being squished. That would not be a good thing.
You're just hanging there by your boobs, suspended.
Held there. I mean, like, it would be horrible. So they literally stop the machine, open up the pancake smasher.
It's a garage door opener.
It's literally
smashing your boob.
Yes, and I lay down on the cold tile floor, topless, like just.
Where was your cape? You lost your cape.
It was gone. It was just too hot for the cape. So she calls another lady in, and I'm just like, I didn't actually fully pass out, but it definitely was a story that they had to tell, I'm sure, for many patients to come. And
oh, man.
Yeah, so.
That's incredible.
Jackie at this last time was.
Jackie's
really good.
Jackie has it going on.
Yes.
So literally walk into the Waterside location. I signed some forms. Jackie's standing there waiting for me. She's like, are you done yet? And I'm like, I've got one more, Jackie. I'm sorry. I'm coming. And then whisks me away. Yes. There's no locker room. It's just bam, bam, thank you, ma'am. And then I was out.
It's amazing.
And then I got my results like later that day.
That's impressive.
On email.
Wow.
So, I mean, I'm saying, I don't know if Jackie's ever going to hear us, but shout out to you.
Thank you to Jackie.
I know, man.
Yes.
Well, gosh, I hope your next one goes better, MK.
Thanks. Well, I mean, this last one was fine. It was the 2 ago that was really
Okay. Well, that's how you know you're in midlife.
Yes.
So
you almost passed out on your mammogram.
Oh, my gosh.
Having a hot flash.
So I think we definitely want to hit hard on all things perimenopause today. Big day, big topic.
Yep.
How does that sound?
I think it's great.
Important. Yeah. We're both living it, for sure, day in and day out.
Yes.
So how did you know you were in the throes of perimenopause?
Well, It was hard. I had so many different symptoms, and I really thought I was going crazy. Mine kind of started during COVID. Plus, I was working on my dissertation. Plus, I had torn my ACL and was so I had so many things happening that part of me wondered, am I just super stressed? Am I just really overwhelmed? Is this just a difficult time of life? But it was really all the things. Some of the symptoms that I noticed were definitely the night sweats. That was probably the first thing. Waking up in the middle of the night just wet, which was just very disturbing and not great. The brain fog, for sure. Hair loss, like I started noticing just the shedding, and even my hairdresser, I asked her, I said, I don't know if I'm making this up. Would you check, when you're washing my hair, if you notice a difference? She confirmed it. Pretty much when I looked at a list of perimenopause symptoms, I checked all but 2. It was pretty much all of them.
Yeah, for sure.
What about you?
For me, it was about age 39. And again, I think it was a perfect storm of things. I was training for my very first marathon. I had decided I wanted to run one before I turned 40. Had no idea what I was doing.
Right.
I have been a runner all my life, but not a long-distance runner. I was a sprinter in college, but found a training program online and was like, this looks good, let's do it, and started, just running a ton, had no idea how to fuel my body for that kind of mileage. And I think that stress plus being 39 equaled some major changes. And for me, it was weight gain.
Right. Yes, I had that as well. Yes.
My whole life previously, if I put on a few pounds, I knew I just needed to tighten up my nutrition, eat a little cleaner, work out a little more, and boom, I dropped that extra, 5 pounds or whatever. And all of a sudden that wasn't working. Yeah. And that scale just kept going up and up despite me running all these miles.
Yeah. So frustrating.
And I couldn't figure it out. I was like, what is wrong with me? So this is a conversation I have just about every day in my office. A midlife woman coming in with similar stories like ours. And, like you said, I thought I was going crazy.
Yes.
Like that really is a high yield quote that I hear.
Yeah.
Something is wrong. I don't feel like myself. I feel like I'm going crazy. So I'm so glad we're talking about this today. Women need to know that they're not going crazy.
Right. Yes.
Yeah.
So important. And even in my office with mental health, they'll come in and say they haven't really experienced this anxiety before. It's more of a recent onset. Describe some of the symptoms that they're having. I'll look and see, check their age, and I'll ask them, have you talked to your doctor about perimenopause? I'm wondering if that's a factor here. And a lot of them respond with, I think I'm too young for perimenopause. It's not that, is it?
Yeah. So let's talk about it. What is it? How do we define it? How do you know what is actually going on? What is this process physiologically? So perimenopause can be anywhere from age 35 to 45. And interestingly, at age 30, we only have about 10% of our egg supply remaining.
Wow. 10%.
10% at age 30.
Wow.
Now, I don't want that. I'm sure it will cause alarm to my 20-somethings and 30-somethings who may be listening. But the truth is, for most women, that's still plenty of eggs to conceive if they're still interested in starting their family or growing their family. So try not to stress. We know stress is bad for so many reasons, especially fertility. But what that means is that we're born with all the eggs we'll ever have.
Right.
We do not make more eggs. Very different from male physiology, right? They're creating new sperm all the time until they die.
Right.
That is not us.
No.
We get what we get. We actually have the most number of eggs when we are a 20-week fetus in utero.
Wow, that's fascinating.
And then we dramatically lose eggs from there on out.
It's all downhill from there.
It's really, truly all downhill. So age 30, you've got 10% of your eggs left. And what that means at this kind of 35 to 45 range is your hormones are struggling. They are continuing to try to push out an egg to ovulate. And that is what we're used to if our hormones are imbalanced, if we don't have a hormonal dysfunction, such as a thyroid disorder or polycystic ovarian syndrome or premature ovarian insufficiency. These are all other conditions that can affect ovulation. But if you are an ovulatory female in your reproductive years, you are very much used to the hormonal cycle, those highs and lows of estrogen and progesterone. We have a hormone called follicle stimulating hormone that comes from our brain and stimulates the ovary to release an egg. Luteinizing hormone, which again is part of that ovulation process. And these hormones all work together to push out an egg, to release that egg to ovulate. And when pregnancy does not occur, there's another hormonal shift, a drop in progesterone that signals that uterine lining to shed and have a period. So we get very used to this symphony of hormones. Ovulate, you bleed. Ovulate, you bleed. So on and so forth until
dun, dun, dun.
You're at the end of that egg supply. Then things just really go haywire.
Is it like your body literally feels we're near the end, so we got to slow this down?
Well, if only.
Okay.
Right? If only it was this beautiful linear trajectory downward. That would probably be better and not affect us so severely. Instead, it's this very much sometimes an overshoot of hormones trying to compensate and really work hard, and so levels get really high. And then perhaps, a few weeks later, they drop really low. I mean, it's like a freaking roller coaster.
Right.
And that's how you end up feeling, like you are on a roller coaster. So periods, in fact, one of the earliest symptoms is irregular periods or a change in the menstrual cycle. Maybe heaviness. Maybe you're starting to bleed every 2 weeks instead of every 4 weeks. So that's a sign that a lot of women have at first. Definitely, I see that a lot in the 40s. I tell women in my office when they're coming in for a checkup, a well woman, kind of test the waters. How are the periods? And I tell them, expect the unexpected, basically, in your 40s. All bets are off, for sure. So hormones are really just up and down. I loved this analogy from Dr. Amy Shaw. I've mentioned her previously. She has a lot of great information out there. She's the author of a few books. One is I'm So Effing Hungry. Another is I'm So Effing Tired. And she really digs into the hormones and explains them in what I think is just such an easy to understand way. So she described the hormones each month trying to ovulate as being at the end of your toothpaste tube.
Wow. Okay.
So, and that was me this morning. Charlie left like a little bit of toothpaste. He loves to do that. And like, just throw it away. Like, why? But you squeeze that little bit, and sometimes you squeeze and it like you get this whole blob, like you get a ton, right? And then another morning you squeeze and you can't get any.
Right.
So month to month, that is similar to what our hormones are doing, trying to release this egg.
Okay, that makes sense.
Yeah. Wild stuff, right?
Yes.
So while it's up and down and crazy levels, it is a progressive downward shift, but it's the highs and the lows and really the unpredictability of it all that causes a lot of these symptoms.
Right. And so all the frustrations too, because you're just really not sure what to expect in each day.
Absolutely. Well, another thing is labs, right?
Right.
So coming in, getting your labs checked. I mean, if you, it absolutely depends where you're at on this whole graph. You still may land in the middle, in the normal, but it's not normal because it's the pattern and it's the trend and it's the ups and the downs.
Right. Yeah.
So that can be frustrating for women when they get labs checked and they hear, oh, well, everything's normal.
Exactly. Which is what I was told. And
Were
it was
you?
so frustrating. Like, what's wrong with me?
Yeah.
And that's just really difficult because, you're looking for answers for sure. So what are some of the myths that are out there, would you say?
Well, I think that's a big one, right?
Labs.
Labs are normal. Good luck.
Yeah, you're on your own.
And it really does matter where you're at in your menstrual cycle to compare those levels on where you should be versus where you are.
And what is the where you should be? Is everyone the same or is
And
is
everyone's
that
not the same.
That's what I thought.
Everyone's not the same. And because we're not really having a menstrual cycle, because ovulation is so sporadic and irregular, it's a shot in the dark.
Right.
It really is a shot in the dark. Now, if something is at either extreme as far as a blood level of estradiol or testosterone, obviously if it's undetectable testosterone, you're deficient in testosterone. And, we can talk definitely about testosterone supplementation in women. But otherwise, if you land in the normal range, it's really hard. It's hard as a physician to explain this to a patient because, of course, I know what she's feeling. I've been there too. And so just navigating that. So I recommend, really treating the person, not the number.
Yes.
And looking at clinical signs and symptoms to know, are you better on this dose of hormone? What sort of side effects are we having? Are we headed in the right direction based on how they feel and not based on a blood test?
Okay.
Yeah.
Yeah. Are there any other myths out there about?
I think you're too young. I think if a 35, 36-year-old comes into my office and is describing some of the things we've already mentioned, I never want to tell them they're too young to be experiencing this because it does. And it can be temporary too. Sometimes, just like, you're getting to the end of that toothpaste, you may have a few good squeezes where for a few months, everything actually feels okay. And then you may fall back kind of below that dotted line of hormone levels or just symptoms exacerbate.
Yeah.
Again, so I, always want to validate patients what they tell you.
Right.
Because only they live in that body. Right. Who am I to say, no, that can't be, or no, you don't feel that way? I mean, that's medical gaslighting 101, and they know what they feel. They've lived in that body for 35, 40, 45 years. Right. So they are truly the expert for themselves, and it's our job to listen.
Yeah. Yeah. So what are some of the options out there for people when they're feeling these symptoms? Well,
there's some good ones. And I think other symptoms, everybody, of course, really focuses on the hot flashes and night sweats. And here's an interesting fact about that. We call those vasomotor symptoms. There are truly, I can think of one other condition, pathology, where you would have night sweats. And that's, well, maybe two. Tuberculosis.
Oh, gosh.
Which thankfully we're not seeing that. Right. But there's really nothing else that causes hot flashes and night sweats. So as a result of that, when patients described having hot flashes and night sweats, doctors knew, like, oh, well, then it has to be perimenopause, menopause. But some women don't have this strong vasomotor presentation.
Right.
And so I think for so long, if you didn't have those, then you weren't in menopause. But the vasomotor symptoms are not the end-all be-all, right? We've just always used those because no other medical condition, they're unique.
So what causes those vasomotor symptoms with the hormones?
Well, it's the rapid changing and the ups and the downs. So the decline in the estrogen and progesterone for sure. Yeah. So while that's kind of this classic telltale sign of perimenopause, I've been surprised by other symptoms that I've presented with and that my patients have. So, for example, joint pain.
Yes. Oh my goodness. I had that in my right foot. I was like, did I do something? Did I hurt my foot? And then after I started the patch, like it literally went away. Like it was but every day, like I couldn't walk barefooted. It was the strangest thing.
And I wonder if your ACL, you mentioned that.
Yes.
So there are estrogen receptors in our tendons, in our ligaments, and in our bones. In fact, there's been studies showing that frozen shoulder
I heard about that.
Dramatically increases in frequency in the perimenopause and menopause population.
Wow.
Because of the decline in estrogen specifically. So I have a good running friend who's been struggling with some hamstring problems, hamstring tendon, like right there at the insertion point where it kind of goes into her glute. And, you know, I've had some of those issues as well, kind of hamstring specifically, like, and I really believe women suffer more in midlife to these types of injuries compared to our male counterparts. So
just because of that drop in estrogen, it makes us more prone to those injuries.
Exactly. So I've had rotator cuff issues. I had to have a surgery to repair that. It was an old injury. Actually, back in residency, I tried to wakeboard, thought that would be a great idea because, you know, why not?
Why not?
And I knew I had messed it up immediately. Like, felt it pull, went down, and of course didn't do anything about it. Didn't get it checked out. Knew something was wrong. Just kind of ignored it. Thought it would go away, and it did go away until midlife.
Right.
And then it reared its ugly head, and I'm like, I couldn't do a push-up anymore. I was having trouble, you know, taking off my sports bra because of the pain. Like, it was, and so finally I had to go get it checked out and get it dealt with, and thankfully I'm all good now. But I really think the hormonal changes of midlife were a big contributor.
Yeah, that makes sense.
So joint pain, ligaments, of course,
which I think people don't normally think about the connection there.
I think probably the hair thinning. Maybe they do, maybe they don't. That's definitely a big part of what I've been experiencing, and that really affects women.
It does.
Our self-confidence. So there are some evidence-based things that can be done to help promote some hair growth. Vitamins, we have no financial disclosures, unfortunately, but Nutrafol.
Yes, I've heard that that's helpful.
A big brand. You have to stick with it, though. You really have to be on this and take it for at least 6 months before you're going to be seeing some improvement. There's some data about red light therapy to the scalp improving. There are topical options. Minoxidil is actually a testosterone blocker that you can buy over the counter in a foam form. You can get it at Target. You just want to wash your hands really well after you apply it, and only apply it where you do want hair growth. So don't touch your face. Just put it on the scalp. And then some iron deficiency. So this is a opportunity where labs actually really are helpful. So checking ferritin levels. Really for athletes, and female athletes specifically, I know I want my ferritin level to be probably around 70. So I'm deficient right now. I actually had this checked because I just felt like, gosh, my hair is still falling out. I feel like I'm trying to do all the right things with the vitamins and the hormone replacement therapy, and why am I still losing all this hair? Also realize that our hair will go through a life cycle, and we will have a huge shedding event 3 to 6 months after something traumatic or stressful.
Right.
For me, that was my last marathon. So I ran the Berlin Marathon back in September. And so I was kind of backtracking, doing the math of like, okay, of course, I'm losing a lot. That was, 5 months ago. So I'm hopeful things will get better, because lately it's been pretty scary in the shower, just like handfuls, right?
Yes.
So the hair thinning is a big one for perimenopause. I think another surprising one is heart palpitations. And that goes alongside anxiety and feeling like you're having panic attacks. And again, it's estrogen is a big part of it, progesterone levels. These play a big role. But there are estrogen receptors in our cardiovascular system. And as estrogen levels are fluctuating, heart palpitations can definitely increase. I also see this in pregnancy. My pregnant patients will come in, and that is a very common symptom that they report, that they're having more heart palpitations, feeling like their heart is racing.
Wow. Yeah.
And it's all hormonal. A big of it,
But
big
scary.
part of it.
Scary I had a client talking to me about this the other day. Yes.
Yeah, it is. It's unnerving because it's new. You've never felt this before, and you just feel like, what is wrong with me?
Right.
Yeah. So I know we're going to hit up anxiety in the future, but I know for me that was also a big change.
Yes.
And so supplementing the hormones has dramatically helped with some of these mood changes and anxiety that I've noticed.
Yeah.
So, other symptoms I'll just mention, a lot of GI changes.
Oh, yeah.
Constipation, bloating. That also has to do with pelvic floor changes, which again are due to hormone changes, decreasing estrogen levels specifically. So if there's some pelvic floor dysfunction, some laxity, some weakness, that can contribute to changes in bowel movements, making it harder, making, constipation more common.
Right.
Yeah. So I think those are some big ones. Can you think of anything else?
Well, of course, a lot of people experience sex change, like as far as not a sex change, but change in their desire.
Yeah, libido.
Libido's
a big one. And
vaginal dryness.
Oh yeah, so multifaceted. Libido is just a bit of a Pandora's box. Yeah. Hard to treat.
Yes.
I don't think enough attention has been given in the research in studies for women's libido.
Right.
Hopefully that's going to be changing. But yeah, if it hurts, if you have vaginal dryness, if it hurts to have sex, your brain is going to tell you, we don't want to do that. Right. No, thank you.
Yeah.
And so therefore desire drops off. Yeah.
Which affects the marriage, which affects the family, which affects so many things. So I think that's the thing too. Perimenopause isn't just about that one woman. It affects all the people around them. And actually my daughter Lydia was laughing because most of her friends, their moms are all in perimenopause, and they were laughing about the things they're noticing in their moms. And so like just the different mood swings and stuff. So
yeah,
it's funny to just hear it from a teenager's perspective.
Yes, I'm sure they pick up on it.
They do. Yes.
What is going on with mom?
Right. Exactly. So it's funny.
That's so true. But there's a lot of changes in the relationships. I mean, no woman is an island.
Right.
So whatever we're experiencing, there's going to be overflow. There's going to be this distribution. The sidelines aren't always a safe place when you're dealing with a woman in perimenopause. I read that divorce rates significantly go up for women's, kind of midlife.
Yes.
And I just wonder
how much of it is affected by perimenopause.
If more women,
gotta be a factor there.
If more women were treated and had better access and were open to menopause hormonal treatment, would that potentially help with relationships and jobs? I mean, I love my patients so much and just love how honest and vulnerable they are with me. I know you feel the same, but I had one woman come in and she's like, Dr. Irwin, you've got to do something. I'm going to kill somebody at my job. There will be a murder if you do not give me some hormones. So I was like, all right, let's talk.
Let's get this done.
Let's make it a safe place at your workplace.
Yes.
But that's just the reality.
It is. Yeah. And I think just being able to talk about it, I feel like that's becoming more acceptable and easier for women to do, but just to be able to notice and see all these symptoms are related together, I think is helpful, instead of just, I'm having this weird thing, that there's a common cause for all of them.
I love being that person who can put all the pieces together.
Yes.
And sadly, I have a lot of patients who do come to me later down the road after they have gone to cardiology, dermatologist, GI doctor, orthopedic doctor, because they're having all the symptoms that we've already mentioned. But it turns out we need to get their hormones balanced. We need to supplement their hormones, and everything will fall into place. Hopefully. Maybe not everything, but a lot of these. It will help. We could do better.
Right.
So I've had that experience time and time again.
Yeah. So tell us about some of the treatment options.
Absolutely. Yep. So, all right. terminology has changed a little bit. We used to say HRT, hormone replacement therapy. What you may, and I still kind of go back to that. You'll hear me say HRT, and old habits die hard. But the new terminology now is MHT, so menopause hormonal treatment. And it's really just verbiage and just a change of terms. So MHT is what we use. So estrogen, progesterone, and testosterone are all three decreasing as we approach menopause. We talked about how it's not this linear drop, but it's this roller coaster with a downward trend.
And let's define menopause, because I think a lot of people don't understand what menopause actually is.
That is such a great point. So menopause is when a woman will go 12 consecutive months without having a menstrual cycle. And obviously, if she's had a hysterectomy, we can't use that. And so the average age is 51. So if a woman is in or around 50 and doesn't have a uterus, so we can't use the bleeding as a gauge, then we use symptoms, and we can use blood work in that situation. So once a woman is in menopause, there are
so in menopause is after a whole year of not having a period. So
correct.
Up until that one day where it's been a whole year, they are premenopause.
Yes, about 5 to 10 years before that last menses.
Okay.
So menopause means a pause of the menses, right? So so that menopause is a day. Just like menarche is when a woman will start her very first period, age 9 to 16. That's the normal range. On average, I would say it's 12 or 13. So that is the menarche. And then the menopause is that last day when it's been 12 months.
So it's not the day, it's the day that's been after a full year of having it.
That's right.
Okay.
And so everything after that is post-menopause.
So menopause is one day.
Yep.
Before that is premenopause or perimenopause, and then after is post-menopause.
You got it. So all three of those hormone levels are gradually decreasing. We talked about the roller coaster. It's a roller coaster ride to the end. So supplementing those hormone levels is truly helpful in alleviating, improving a lot of the symptoms we've discussed. Now, for perimenopause, I do want to point out that suppressing ovulation is very helpful because that is truly the problem. It's this erratic, unpredictable ovulation. And so if we can override that process using hormones, perimenopausal women experience a lot of relief.
And that would be with birth control?
It can be, yes. So that is what I'm talking about. So suppressing ovulation is using hormonal contraception. And it's important that women realize that as long as you are having periods, you have that opportunity to get pregnant.
Right.
You are still releasing an egg. Now, that egg is probably not a great quality egg because, for me, it's 45 years old. But it's important to know. I saw an article last night. I think Claire Danes got pregnant at age 42, and she was shocked.
Wow.
Like, women are shocked because I think there's this another myth is floating around that, oh, well, once you hit 40, you can't get pregnant. That's is absolutely not true. And I've had many patients who wanted to get pregnant in their 40s and have done so successfully. So, it's two sides of that coin, right? So supplementing these hormones, overriding ovulation in perimenopause, and then supplementing the hormones, in menopause is really what is most helpful for women. And having a reliable form of contraception if pregnancy is not desired is also very critical in perimenopause. So I can tell you, I think we can both feel comfortable sharing kind of what we're both doing in our own lives. So in addition to that kind of weight gain experience, age 39, fast forward a few years, I was sweating all the time. And I didn't realize, it was kind of a gradual, it kind of snuck up on me that I really didn't realize how significant, it was severe. I would finish a C-section in the OR, and I'd take off my surgical gown, and my scrubs would be completely soaked.
Right.
And finally, one of my surgical assistants was like, "Are you okay?
Wow.
Like, you're like really wet."
Yes.
I would feel like I need to go take a shower. And I'm like,
Yeah.
I don't have time for that. I got to get back to the office and see all my patients. But I was just sweating a lot. I would be really sweaty during a vaginal delivery. You know, again, the gown on, take the gown off, sweaty. I'd be sweating through my scrubs, like just making rounds, like, you know, going and seeing patients. So I was like, this can't be right.
Yeah.
This cannot be right. So I think the sweatiness for me is finally, the hot flashing is what finally, you know, made me explore more of supplementing my estrogen. Yeah. So that is a big one. Let's talk about estrogen.
Yeah.
There's many different formulations on how you can supplement your estrogen. So we have talked about birth control. So I think it's a great option for those women who do opt in for that, perhaps in that kind of 35 to 45 range.
And that can be a pill. That can be an IUD.
So an IUD, I love IUDs. I have an IUD.
I do too.
And I have an IUD that releases progestin. It's a levonorgestrel releasing IUD. It's going to last me 8 years. And it is keeping the lining of my uterus very, very thin. And that's important because if you are taking estrogen helps build up that lining. It stimulates the lining of the uterus, and progestin helps keep it thin. So I tell patients it's like the yin and the yang.
Right.
If you have a uterus and you're going to take estrogen, you need some form of progestin to counteract that, because if not, that estrogen will build up that lining thicker, 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 and then that can turn into precancer changes.
Wow.
So a thick endometrium is a setup for precancer and cancer of the uterus. And we are not in the business of creating new problems.
Right.
So an IUD is a great option for perimenopause. Not only does it offer that contraception, it keeps the lining thin if you're going to be on estrogen. And it's not systemic, right? Like you're not going to have side effects, and it's long acting. You don't have to do anything.
Right.
It's in, you're done. So estrogen, though, comes in, there's a transdermal is really our first choice. So that means through the skin. And the reason it's our first choice is because it's safer. That delivery route is safer compared to an oral because there's less risk of developing a blood clot in the deep veins of your legs, or a pulmonary embolism, which is a blood clot that travels to your lungs, and that can be life-threatening.
Yeah.
And so while that risk is low across the board, it's even lower when you choose a transdermal route.
Okay.
So my favorite is a patch.
Yep. Same.
I've got mine on. You've got yours on.
It's patch day.
It's patch day. I like the twice a week patch because it's smaller. There is a patch that's once a week, but it tends to be bigger, and the adhesion is not quite as good in my opinion. But other transdermal routes, there is a gel that you do every single day. Comes in a little packet. You open it up. You squeeze all the contents out. Usually upper leg is what's recommended. Rub it in. Wash your hands. You're good to go. There's also a spray. So Eva Mist is a spray. Has a little kind of a pump, aerosolized. You pump it, spray it on your forearm, rub it in. Good to go. Again, you have to just wash hands. Be sure you don't transmit to children, pets, husband, friends who don't need estrogen.
Right.
Don't share. Don't share. Sharing is not caring in this situation. So transdermal if you can. Now, some patients have very sensitive skin, and it's not an option. So there is a vaginal ring form that you can use, and then there's oral formulations. Yeah. But the estrogen is really going to be what helps with the hot flashes.
Yeah.
And all those other things we mentioned too, the joint pain, etc. Now, like I said, if you have a uterus, you need the progesterone. And not just for that reason, but that's a very important reason, to keep that lining thin. But the progesterone is also important for anxiety.
Yes.
And mood.
Sleep.
Sleep is a big one. Sleep is a big one. So sometimes I have patients, perimenopause, maybe they have an IUD, so they don't need contraception. They're covered there. And really their main complaint is sleep.
Yeah.
I think that's a great opportunity to just start them on progesterone only at first, right? If that's their only complaint is sleep. It can also help with some vasomotor symptoms. Yeah. So I also, even though I have an IUD that's keeping my lining thin, I'm taking my estrogen patch. I also take a nightly progesterone pill, and it helps me sleep, and it helps with my anxiety. Yeah. So I feel like that's a great formulation that has worked wonders in my life. I feel good in this body. I'm sleeping.
Which also makes such a big difference. I mean, just getting sleep, there's a reason that is a torture tactic of sleep deprivation. It is huge.
It is.
It's so important to get sleep. And even if that's not helping, I know giving patients maybe sleep medication if they need that. Sometimes
we need that too.
Yeah.
Yeah. But this is always a great place to start.
Yeah.
Yeah.
Yay.
And then testosterone. So it's, sadly, it's a bit unstudied. We have some good studies coming out of Europe. There's a study that did prove that testosterone was efficacious in improving libido in women at a 5 milligram transdermal dose. But it is not FDA approved for women, and there's no specific women-designed formulation for women. Not yet. Right. And I'm hopeful that in the future that will change. Yeah.
So do you ever recommend testosterone or
I do.
Okay.
I do. I think when the libido is a big complaint, or for women that have dialed in their estrogen and progesterone and still feel like something's lacking, whether it be energy, we also know that testosterone helps with muscle mass and bone strength. So it is important. I mean, we are used to having higher levels of testosterone our whole life until we hit that wall of perimenopause. And we can do these hormones safely. I do want to touch on that. I think that's really the big question that comes up, and the fear that patients may have, the reservation, is it safe?
Right.
And I can tell women that when done right, it is safe. And the big question that women want to know is, do hormones cause breast cancer?
Right.
And I think when we get to that and we really ask them, what is it you're afraid of? A lot of times that is going to be the answer. I'm afraid of getting cancer. I'm afraid of getting breast cancer. So the Women's Health Initiative was a huge study that was released in 2001. And that was the study that really the pendulum shifted. It swung in the direction of taking women off hormones completely. But I want to just briefly point out that the results that were propagated specifically for the estrogen progesterone group was the relative risk of developing breast cancer and not the absolute risk. Okay, so what's the difference there? The absolute risk in the group that was on the hormones who developed breast cancer was 0.08%.
Wow.
The relative risk, however, was 25%. But that's because there were 4 out of 1,000 women in the placebo group who developed breast cancer.
Okay.
And then there were 5 out of 1,000 women in the hormone group who developed breast cancer. So when you go from 4 to 5, that's a 25% increase.
Right.
And that is the number that the media ran away with.
Wow.
Hormones have a 25% risk of causing breast cancer.
Wow.
Not true.
Yeah.
And for these decades, since 2001, we have been trying to get that genie back in the bottle. Because it caused a lot of fear. Doctors were afraid. Doctors heard that number too. They pulled prescriptions. They called all their patients, said, stop taking this, stop taking this. But the truth is 0.08% risk of absolute risk of developing breast cancer on hormones.
Wow.
Few other just important notes about the WHI, the Women's Health Initiative study. The average age of women started on hormones in the study was 63.
Oh my goodness. Wow.
timing is important.
Right.
When we have a big gap from our menopause to initiating hormones, it's not safe. That's what WHI told us.
Okay.
Not that hormones aren't safe, but that timing is critical. And of course, start the hormones when a woman needs them, when she's symptomatic. And in fact, perimenopause, 35 to 45, start treating the symptoms. And then lastly, the only hormone formulations that were used in the WHI were synthetic.
Wow.
So it was a conjugated equine estrogen. So Premarin, you may have heard of Premarin. That word comes from pregnant mare urine.
Oh my goodness.
So they took pregnant horses, they took their urine, and they filtered out the estrogen from the urine. Okay? Okay.
Okay.
There you go.
All right.
And then the progestin component was a medroxyprogesterone. So it's a synthetic progestin.
Okay.
We still use that. We use that in Depo-Provera for contraception. But we do believe that bioidentical hormones, meaning biologically identical to what our body makes, so that's estradiol, and that's progesterone. So we now have these as options to provide our women, and we believe that's safer.
Yeah, that makes sense.
It's good news.
Much better news. So you mentioning that about the study waiting until they were 63. So when do you recommend women start treatment, and when is it too late? And if they're just now hearing this and they haven't had this access, what should they do at that point?
Yeah, good questions. So I'm a believer in starting when you're symptomatic. Now, again, depending on the age, depending on the need for contraception, that may be a very low dose birth control to suppress ovulation, to prevent pregnancy, and it will also provide some relief to some of the hormonal symptoms that they're having. Not for everybody.
Right.
So it needs to be an individualized approach. There is no one size fits all for perimenopause and menopause treatment. As far as when is it too late, the study showed that we really kind of hold fast to 10 years. So if you're more than 10 years since your perimenopause, I personally, as a doctor, encourage other non-hormonal options. They do exist because there are some women who, perhaps they have a personal history of breast cancer. We're never going to give them hormones. That is absolutely not safe, not recommended. Now, a lot of women come in and say, well, I have a strong family history of breast cancer, or my mother had breast cancer. The strong family history, I believe it's important to offer genetic testing to see if they are a carrier for perhaps the BRCA1 or BRCA2 gene, these gene mutations that do predispose women. There are others besides the BRCAs. But having just a relative who had breast cancer, that in and of itself is not a contraindication for your own use of MHT. So that's important.
Good to know.
But
if you've had it, then obviously no. Yeah.
Correct.
Okay. So if they have been basically post-menopause for 10 years, like if they haven't had a period for 10 years, probably not going to recommend.
Exactly. What I will recommend, though, is vaginal estrogen. So the genitourinary syndrome of menopause, that's a lot of words there, but GSM describes the changes that occur in the genital urinary system after menopause due to lack of estrogen specifically. So that's vaginal dryness, pain with sex, more frequent UTIs, bladder changes in general, more frequency, more urgency, some bladder incontinence. These are also very important changes that happen in perimenopause and menopause. And down the road, frequent UTIs can lead to even urosepsis, death in our older population. And so there's good news here too. So even if you are, past that point, 10 years plus, and have never done hormone replacement therapy, MHT, vaginal estrogen is still safe to help with the GSM, the genital urinary syndrome of menopause. And even if you are a breast cancer survivor, you can still use vaginal estrogen. Of course, talk to your doctor, talk to your oncologist. But when we're talking vaginal estrogen, we're talking a cream, there is a tablet, there's also a ring. I will tend to just prescribe the cream because it's cheap, it's easy, it's 2 or 3 times a week at bedtime. The cream goes up inside the vagina, and there is not a systemic absorption.
Gotcha.
This is a localized treatment, and it can be life-changing.
Yeah, that's what I was thinking. I mean, all those symptoms affect your whole life.
They do.
They're huge.
And I truly believe that all postmenopausal women need to be on vaginal estrogen. And it's okay to do vaginal estrogen and MHT. You can do both because sometimes the GSM is severe and you need both.
Yeah. Yeah, that's huge. Okay. Yay. This is all so much helpful information. I feel like all of our listeners are like trying to take notes and hopefully sharing it with other people, whether they're in this stage of life or about to be in this stage of life, because I know, we've mentioned before, I have 3 younger sisters. So I've been just passing on all the resources and information to them. Like, here's what's coming, guys. Like, just prepare yourselves.
Yes.
So it's so helpful to have this information to share and to tell our friends and family, like, you're not going crazy. This is real.
It's real. It is not all in your head. The hormone changes are happening. They are affecting every part of your body. There's really no part of it. Just like in pregnancy, there's no part of your body that is left untouched, unchanged. Once again, we find ourselves on this perimenopause journey, and no part is immune to the changes.
It's all affected. So
hopefully this has been helpful.
Yeah. Thank you so much for sharing all this information. And listeners, we hope that you'll, share this with your family and friends. And if you have any other questions about any of these topics, feel free to contact us. We'd love to help as much as we can. But thank you, Dr. Irwin, for your incredible expertise, and just so excited to get to share this information with people.
It's a journey.
It's a journey.
We'll see you next time.
Thank you for joining us on a journey to whole woman health. If this episode encouraged you, share it with a friend, leave a review, or subscribe so you don't miss future conversations. Remember, your questions matter, your health matters, and wholeness is a journey. Until next time.
Now for the legal language. This podcast is for educational and informational purposes only and is not intended as medical, mental health, or professional advice. The information shared on a journey to whole woman health is not a substitute for individualized care, diagnosis, or treatment from your own physician, mental health provider, or qualified healthcare professional. Always seek the advice of your personal healthcare provider regarding any medical or mental health concerns. Never disregard a delay seeking professional care because of something you heard in this podcast.